911, what's your emergency?
Greetings and welcome to today's episode of Demystifying the EMT. On today's episode, we're talking medical terminology and anatomical positions. So let's get started. When I started coming up with ideas for this particular episode, I sat down and I tried to write down as many medical abbreviations as I could think of. It's been a while, but you can see these are just a handful of the ones that I wrote down. Today we're going to cover probably the ones you use most often, probably about 10 of them. There are literally thousands. This is a pocket guide and has page after page after page of medical terminology. You can get this at any bookstore. You can get it on Amazon. You can get it just about anywhere. This is a pocket guide that I carried. Not that I was a paramedic, but this is the paramedical version. And the reason why I carried the paramedic version is when I'm dealing with patients, medications specifically, if I didn't know what they were, because there are thousands and thousands, most of the common ones are all written in this book, so I could look them up and kind of get an idea. Usually what you do is you would ask the patient, what medications are you taking? And they say, oh, I'm taking this, and they say, well, what are you taking this for? And that should give you some kind of idea. So on today's episode, I want to cover kind of the most common ones. I mean, like I said before, there are thousands of them. So let's start at the beginning, like they say in The Sound of Music, and start at the very beginning. ABC. ABC is what you do for every single patient. I add two more letters to that. I add D and E. And what each one stands for: airway, breathing, circulation, disability, which is your level of consciousness, and exposure, and that's for like traumas. So you would start off every patient and verify the ABCs. So if they're talking to you, then obviously their ABCs are good. But if they're not, then you have to go a step farther and find out, if they're breathing but it's not adequate, or it's shallow, it's rapid, it's slow. Those kind of things will lead you down to what you need to do next for that patient. Once you establish your ABCs, then you move on to D. And D is 4 more letters. So you got your A, V, P, and U. AVPU. AVPU stands for alert, verbal, pain, unresponsive. So if your patient's talking to you, then they're an A. If they're just sitting there and you call out their name, hey Bill, and they look at you, then they're a V. So they're responsible to verbal stimuli. If they're unresponsive to verbal stimuli and you take your knuckles and you rub it right in the center of their chest, right on their breastbone, it really hurts. And if they respond to that, then they are P, responsive to painful stimulus. And if they don't respond to any of the first 3, then they're considered U, which is unresponsive. So there you go. You have your A, B, C. And once those are good, you move on to D. And then for trauma, it's E. E stands for exposure. So let's say somebody has a cut on their arm. So you want to expose that so you can see it and treat it. So that's your A, B, C: airway, breathing, circulation, disability, which is your level of consciousness, or also known as LOC. Another letter, 3 letters you need to learn. So A, B, C, D, E, A, V, P, U, LOC. Like I said, there are thousands of these. And once you establish those, then you move on to the next one, which is OPP, QRST. If you're down with that, then you're down with me. OPP, most people say OPQRST. I add the second P, and it stands onset, provocation, palliative. So when did whatever the issue start, onset? What makes it worse? Provocation. What makes it better? Palliative. And then Q is quality. Doesn't mean it's high quality or low quality. It's a descriptor of what the pain feels like. Like, is the pain a crushing pain, a stabbing pain, a burning pain, a tearing pain? Those are what's referred to as quality. R is radiation, not radiation like in a nuclear bomb. Radiation as does the pain travel anywhere else. So if someone says, oh, my chest hurts, and it's radiating up my jaw, that's a pretty good indicator that that patient is experiencing a heart attack. Not definite, but a good indicator. So OPPQR, S stands for severity. How bad is the pain from 0 to 10? A 0 being no pain, a 10 being the worst pain you've ever felt in your entire life. Anyone's ever gone to the hospital has had any kind of pain, they show you the little picture that has the smiley face and then the sad face that's crying. That's your pain scale. And if they say that my pain's a 10 out of 10, that's pretty significant. You kind of have to take them at their word for it when it comes to pain and severity of pain, because there's no way for you to tell whether or not that patient is in that much pain or not. But technically, you need to treat it as such. So if they say I'm a 10 out of 10, then you treat them as such. Obviously, as an EMT Basic, you're not really going to do anything pain management wise. That's a higher level skill. Only thing you can really do is kind of, give them an ice pack, give them some oxygen, little things like that. And then the last is T for time. So how long has this been happening, basically? So you A, B, C, D, E, A, V, P, U, O, P, P, Q, R, S, T. So, like I said before, there's all these, and these are for every patient you will deal with these acronyms. Well, not acronyms, abbreviations. Another good one that you'll see a lot is when you take a history. There, you can do a sample history, you can do a S sample history, or you can do an ample history. And each one of those letters stands for something different. So in a sample history and ample history is identical. The only thing is different is you don't use the first S. So S is signs and symptoms. So a sign is anything that you can see. They have a broken arm and they have a bone sticking out, that's a sign. If they say, I'm having stomach pains, that's a symptom. So you got to keep those in your head of which one is which. A sign is something that you can see, and a symptom is something that the patient tells you. I'm having difficulty breathing, or my leg hurts. Those are symptoms. The next A in the sample history is allergies. You need to ask every patient, especially drug allergies, are you allergic to any medications? A lot of times you'll hear something like, I'm allergic to penicillin, for example, or codeine, for example. So what you want to do is basically, especially aspirin too. So if you're going to give an aspirin, make sure your patient's not allergic to aspirin, because if you give an aspirin during your test, if your state allows EMTs to give aspirin, if you don't check to see if your patient is allergic to aspirin, I guarantee you your patient will croak on you. Not croak on you, but will have symptoms of allergic reaction. So that's part of the patient assessment is S, signs and symptoms. A, allergies. M, SAM, is medications. Are you taking any medications? What amounts do you take? When do you take them? Did you take your medications today? Did you take anything after this issue happened? Those are all questions you want to ask the customer, the patient, excuse me. So you want to ask them directly, are you taking any medications? What are you taking? How often? What do you take that particular medication for? So if a patient is taking like a antidepressant, for example, or a narcotic painkiller. These kind of things will change the way you treat the patient. Not so much at the EMT basic level, because EMT based patients are basically treated all the same: airway circulation, transport, oxygen, ALS intercept. That's pretty much how every patient will be treated. Some protocols allow other things, but that's your basic patient care as an EMT basic. And then the SAMP is pertinent past history. Have you ever had this before? How often? Like, someone might get like hay fever, for example. They get it every spring. If it's not pertinent to the issue at hand, it's probably, you don't really need to know that. It's pertinent past history. I'm having a heart attack, or I'm having chest pains. Have you ever had a heart attack before? Yes. When? What was the treatment? Were they given a cabbage? Another one, CABG, coronary artery bypass graft. So it's another abbreviation that you'll come across all the time, cabbage. So you want to get the pertinent past history. That's the P. L is your last oral intake and last menstrual cycle. And the reason why you ask that question is if you're dealing with a female patient that's between 12 and about 50, they're in that childbearing age. So you want to see if there's any possibility that they might be pregnant. Be careful when asking a 12-year-old, because they may be shy and not want to answer that question, or their parent might be there nearby, but so you need to know when the last time they ate was, what they ate, and then for female patients of childbearing age, last menstrual cycle. And then is events, what led up to the current situation that they're having. I was out mowing the lawn and I started to get chest pain. Okay, that's a pretty good indicator of angina, which is it's not a life-threatening condition, but it's a scary condition. A lot of people get chest pains after doing some form of exertion. So that's sample and ample. They're identical except for you take off the S on ample and there's no signs and symptoms. S ample or S sample is the same exact thing as sample and ample, except we add one more S, which in this case is social drugs. So you want to know if they've taken anything. Obviously nowadays marijuana is legal in a lot of states. So you want to ask your patient, have they taken any social drugs? If they're reluctant to answer you, which it happens, to say, reassure them, I'm not a police officer, I'm not here to bust you, I just need to know because it's going to change how I treat your condition. So if someone says, yeah, I just did cocaine, you probably don't want to give that patient nitroglycerin. So those are some of those or Viagra. If a patient has taken Viagra, you definitely don't want to give them nitroglycerin. But those are more, we'll get into those like cardiac type issues once we get a little into that section. So those are basic ones you'll see on every call. Another one you'll see a lot is ETOH, which is a chemical signature of alcohol. So you ask the patient, have you had anything to drink? When's the last time you had a drink? What did you drink? How much? And these kind of things, there's not really much you can do, but you want to relay that on to the hospital when you make your patient report saying patient was at a party and had 3 drinks in the last 2 hours. So, or you can just simply say the patient has ETOH on board. So when you call and do your patient care report, this is so-and-so, we're en route to your facility. On board I have a 32-year-old female with sudden onset abdominal pain. Patient was sitting in a chair at a party and started having pains. Vital signs are blah 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 blah. Patient is ETOH times 3, or something to that effect. Well, and we'll get into those patient care reports once we get a little further down the line, but this is the kind of basic stuff you need to know. There are tons of them. JVD is one you'll see a lot in trauma patients. That's jugular vein distension. So there's two veins that run from your brain to your lungs. They're called jugular veins. So you got your carotid arteries that carry blood to the brain, and the jugulars carry it back to the lungs. So if they're all puffed out, you can see them, that's JVD. Let's see, what's another good one that you'll see a lot of? CC, or C/C, chief complaint. Why the patient call 911? I was having difficulty breathing, that's their chief complaint. A and O, A ampersand O, alert and oriented. There are ways of describing how alert or non-alert a patient is. So if they're alert and talking to you, they can tell you their name, the date, who the president is, what day of the week. So those are four criteria. So they can answer all those questions correctly. Then they're A and O times 4, or alert and oriented, person, place, time, and then time of day, or day of the week, or something along those lines. MVA, MVC are used interchangeably. It's a motor vehicle accident, motor vehicle collision, same thing. MOI/NOI, which is mechanism of injury, which is a trauma term. If someone falls off a ladder 10 feet onto concrete, that's a high mechanism of injury. If someone trips and falls from standing to the ground, that's not a high mechanism of injury. Nature of illness, or NOI, is basically what the patient is experiencing at that given time. So the nature of illness is for your medical patients. MOI, or mechanism of injury, is for your trauma patients. AMS is one you'll see all the time. AMS stands for altered mental status. So if someone is, alert and can carry on a conversation, and all of a sudden they're often not on land, they have altered mental status, and a lot of the time that's a symptom of hypoxia, which is a lack of oxygen to the brain. It could be a symptom of heat exhaustion, heat stroke. It could be a symptom of a lot of different things. Stroke. Altered mental status can be a sign of stroke. Or CVA, another one, which is cardiovascular accident, which is the same. It's a stroke. It's just the medical term for a stroke, a CVA. There are different kinds of strokes, and we'll get into those once we get into neurological emergencies. But basically, you want to remember FAST, which is another acronym. FAST is a kind of a troubleshooting path to check to see if someone's having a stroke. So FAST is like face, so facial droop on one side is probably the one that's most readily noticeable. Altered mental status, slurred speech, and time. Last known well time is the last time that they appeared normal. So especially with a stroke, you want to be very quick. You want to get that patient to the hospital right away. It's one of those that's an emergency, a very critical, life-threatening condition. There are ways to treat a stroke, but the longer there is a delay in recognition, transport, definitive care, it's really indicative of whether or not that patient will be able to recover. So time, last known well time. Another thing you'll see is like partial paralysis. And usually strokes affect one side of the body, so it's kind of confusing, but the right side of the body controls, or the right side of the brain controls the left side of the body, and vice versa. So if somebody is paralyzed on the left side facial droop, eyes, slurring speech, can't puff out their cheeks, then stroke's usually on the right side. The same thing on the other side. So if the right side is, like, you lift up their arm and just falls back down, paralyzed, it's because the left side is affected. So keep that in mind, and we'll get into more detail on strokes once we get to neurological emergencies. Like I said before, we're going to build on each lesson, so the goal is to give you just enough information to make it so that you have a basic understanding. So that's pretty much what we'll go over for your medical terminology and abbreviations. Like I said, there are thousands of them. These are the ones you'll see the most common. And as we progress in these little workshops, I'll introduce new ones and explain them at that time. But for now, I think this is a pretty good primer for what's coming next. Now, I kind of want to talk about not anatomy as in, the collarbone's connected to the thigh bone, that kind of anatomy. I mean, obviously, I'm blowing that out of proportion. I'm just, none of those are accurate. It's a song, right? Knee bone's connected to the thigh bone or whatever. But I want to more talk about how the body is organized and divided for medical care. So a patient straight on, head erect, standing straight up, palms outward, and they're pointed to the side, so the thumbs are up, forward. That's what's called basic anatomical position. So you're looking at basically the front side of the body, palms forward, thumbs to the outside. That's your basic anatomical position. Now, if you take a line and you draw it from the very tip of the head, down the center of the face, through the nose, through the mouth, through the center of the chest, all the way down to the pubic bone. And then, so you basically divided the left side of the body in half from the right side of the body. That is called the midline. So the midline is top of the head all the way through the pubic bone. So basically, everything on this side is on the right side of the body. Everything on this side is on the left side of the body. You'll see that a lot, especially when you're dealing with a patient that could potentially have a pneumothorax. What you'll see is if there's one lung down, the trachea, the windpipe, will deviate to one side. And so when you give your report, say trachea is midline, then that tells the hospital you're not suspecting a pneumothorax. And we'll get into those injuries once we get into trauma assessment and kind of the more intricate diagnoses that you'll see. Now, if you were to take the collarbone that runs from here all the way through here, this is called a suprasternal notch. So this bone all the way across is the clavicle. So you draw a line from the center in between the notch here and the shoulder, draw this line straight down. That's called the mid-clavicular line. So basically it separates the body into another half. So you got half and then two halves and two halves to make one whole. So two halves make the right side whole, two halves make the left side whole, and then those two combined make the whole body whole. So that's called the mid-clavicular line. Underneath the armpit, running basically straight down, where you can see kind of where the seam of my shirt is, that's called the mid-axillary line. So you ever hear someone say, I took an axial temperature, it means they used the armpit as a place to take a temperature. So this line is called the mid-axillary line, and that divides the front of the body, or you can say the anterior or ventral, which those three terms are used interchangeably. So front, ventral, anterior are the front. So everything in front of that line, the mid-axillary line, is anterior. Everything to the rear of that is posterior or dorsal. If you take the body basically at the waist and everything above that, that would be considered superior. Everything below that, like the legs and lower extremities, will be considered inferior. It's not one's better than the other. It's just a way of dividing the body in half, top to bottom. So we had the midline, which is, middle torn half, and now we've got this part up, superior, and down, inferior. You can also use different terms called distal and proximal. Generally, you wouldn't use it up and down, inferior, that's inferior and superior. But let's say from the shoulder to the fingertip on an outstretched hand, and you want to say the fingertips are distal to the shoulder. So the way to remember that is distal equals distance. So fingertips stretched out is distal, shoulder proximal. Okay, there is a couple others, but these are the ones you'll see most commonly. If you take the arms and then lay them straight down at the side and you raise one up and away from the body so it's parallel, that is called abduction. A-B, to abduct or to take away. To bring it back towards the body, it's called adduction. A-D. So like you're bringing it back, adding it back to the body. So abduction, adduction. Distal, proximal. Inferior, superior, inferior, superior. Midline, mid-axillary. So remember those. Those are the way you describe. Let's say if someone has a gunshot in the left chest, you can say, 2 centimeters lateral to the mid-clavicular line. So here's another one. Medial, lateral. Medial, think of middle, lateral to the outside. So the breastbone is medial to the shoulder. Middle, and then lateral. So just remember that. Medial, middle. If somebody is laying flat on their back, face up, that's what's called supine. You'll see that a lot. Patient was found supine in bed. Whenever you write up your report, you want to write out how you found that patient. So flat on the back, looking up, supine. Turn them over so they're flat on their chest and belly, looking down. That's prone. So you remember, up, supine, face down, prone. There are a couple other ones. So someone's sitting half upright, so they're kind of reclining. That's called fowlers or semi-fowlers. Like if they're straight up and down, fowlers. Reclining, semi-fowlers. Most of your patients will probably be, when you got them on the gurney, in that semi-fowlers position. What I usually would write on mine is place patient in POC, which is another abbreviation. POC stands for position of comfort. POC. You see a lot of people with chest pains, or not chest pains, difficulty breathing. They want to sit straight up because when they're sitting back, it's really hard for them to breathe. So you want to note that. Another one to remember is Trendelenburg, and Trendelenburg is feet up, head down. That's what we would consider shock position. Now, shock position, you want to try and get all the blood going towards the vital organs. So you raise their feet to allow that blood to be pulled towards the center. And usually you want to try and keep them warm if they're like in shock. There are different kinds of shock. We'll get to those when we get to that section. I'll go over those once we get to that section. But just remember, so fowlers or semi-fowlers is upright. Trendelenburg is the opposite, feet up, head down. And then you can further have someone on their left side or the right side. Left side is left lateral recumbent. So basically, you put it so that their head is resting on their hand, kind of like this, and that kind of the sleep position. and then you kind of bring their knees up to their chest, kind of in that fetal position. And the idea of that is it's called the recovery position. And the good part about being in this position, so they're on their side, is if they were to vomit, they don't aspirate. And what I mean by aspirate is breathe in that vomit back into their lungs, which can be very dangerous. So you don't want them to do that. So you put them on their left side. That way, and maybe turn their head down a little bit. So if they do vomit, it's not going to be aspirated as easily as if they're flat on their back. Obviously, if you're flat on your back and you vomit, as gravity, pull it back in, take a breath, breathe that crap into your lungs, and you basically drown on your own vomit, which you see a lot in drug overdoses. It happens all the time in drug overdoses. And you can do the same thing on the right side. So that's right lateral recumbent or recovery position. When you're dealing with a pregnant woman who is obviously pregnant, has, you know, the pregnant abdomen where there's, you know, they're pushed out, you want to put them on that left side because there's a vein, it's called the inferior vena cava, which is the main vein that brings all the blood from the toes and the legs all the way up to the lungs. So you want to lay them on their side because the weight of that fetus can press down on that vena cava, and it can cause the blood to not be able to get back to the lungs. So thus your positions, your midline, your lateral, axillary, recovery position, prone, and that's basically what we need to go over today. So we've gone over medical terminology and abbreviations, and anatomical positions, and also kind of a quick primer on transporting a patient. We'll go into more detail later on once we get into the ambulance operations. Basically what I want to cover today is those items. The next episode, that could be kind of dry, but it's important. We're going to go over bloodborne pathogens and PPE, or personal protective equipment, sometimes called BSI, body substance isolation. Same thing. It doesn't matter. You can say PPE or BSI. The meaning is identical. So that's on the next episode. So thanks for watching. Demystify the EMT, and we'll see you on the next one.
911, what's your emergency?